Doctor, we are live now.
We are live. Thank you so much, Dr. Manjulari. So let me first introduce our mentor for today. We have Dr. Deependra sir. He is the present medical director at Retina Services, IQI Hospitals. Sir has been practicing VR surgeries for the last 22 years. Sir has authored more than 75 publications and has 16 book chapters to his name. Sir has won the honor award by the American Society of Retina Specialists, and he is one of the core members of the Delhi Retina Forum. Sir is also presently the editor of Haryana Journal of Ophthalmology and the associate editor of International Journal of Diabetes in Developing Countries. So, welcome, sir. And our topic for discussion today is submacular hemorrhage and a masterclass for you. I would want to bring in our first. uh, So I would like to invite our first speaker for tonight. We have Dr. Vishnu here. Dr. Vishnu today is a senior resident, a second year MCH candidate at Advanced Eye Center PGI Chandigarh, and he did his post graduation from AIMS New Delhi. So over to you, Dr. Vishnu, and can you present your
Yes,
case?
sir.
Thank you.
Is my PPT visible?
Yes, 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 Doctor.
Hello, everyone. Since I have already introduced me, so I'll directly begin to present my case. Uh, a 48-year-old hypertensive male presented to us with a sudden decrease in vision in left eye for 3 days. Below, we can see the optos fundus picture. The positive findings in the case was there was a pre-retinal hemorrhage along the superior arcade, and which is depicted by a yellow arrow, and there was a red subretinal hemorrhage, which is depicted by a red arrow, which is along the inferior arcade, and which is crossing both the arcades. On the side, we can see a fundus autofluorescence picture, which is showing a hypoautofluorescence depicting a fresh subretinal hemorrhage as well as fresh preretinal hemorrhage. The main aim of our surgery was to displace the subretinal bleed from the macular area so as to identify the primary pathology and to treat it. So a 25 gauge pars plana vitrectomy was planned. Currently, we are doing core vitrectomy. PVD was induced and peripheral vitrectomy was done. After completing posterior vitreous detachment, we can see a sub-ILM bleed on the superior arcade, which was aspirated using a cutter. We can see a flimsy ILM over the pre-retinal bleed. Which is aspirated. We could also see a subretinal hemorrhage, which is extending beyond the arcades. And we can see a ruptured retinal artery macroaneurysm, which is along the superior arcade. Now we are using a 41 gauge subretinal cannula. And now for pneumatic displacement, we are using a 0.4 cc balanced salt solution, which is injected in the subretinal space to create a bleb. PSA solution is being injected. Then a 0.3 cc of filtered air is injected to displace the subretinal bleed. Then a fluid air exchange was done. following which 20% SF6 was given as a gas tamponade. This was the post 6 weeks post PPV. Media was grade 1. We can see hyperautofluorescence along the inferior, at the inferior fundus, which is because of old subretinal bleed. Below is the OCT picture, which is showing intact photoreceptor layer, and the patient after 6 weeks had the best corrected visual acuity of 6/18. Thank you.
Excellent video, Dr. Vishnu, and a very good case to begin with. Before going into the discussions, I would want Dr. Deependra sir, if you can start his presentation, and we'll come back to your case with some discussions on your case as well.
Sure.
Thank you. So if you can please discuss or share your.
Thank you once again, Dr. Avnish. I thanks all your team, and it's good to see all bright young retinal surgeons on the same forum today. And I think this topic is now getting vaster and vaster, subretinal hemorrhage. And earlier it used to be just discussion about pneumatic displacement or treating the etiology, but now we see a lot of different innovative techniques coming up to manage this. So I think I'll just to set the context. In general, in your practice, when you see a patient with submacular hemorrhage, there is actually either one of these two scenarios. Either it happens to one of your older patients who you have been treating for neovascular AMD for quite some time, and they'll end up with submacular hemorrhage, or it comes like a bolt from blue, a treatment naive patient who has not undergone anything, and he or she presents with submacular hemorrhage. So I think in first scenario, I think you are only worried about RP rip, and blood once you are going to displace it. Prognosis will entirely depend on whether that RP rip has happened and is it crossing fovea or not. But in this treatment naive category, you have to also look for etiology. And in pre-operative assessment, when you are seeing these patients, besides a good fundus photograph, I think OCT gives you very good information, as I'll show in subsequent cases, especially where all this blood is located, how much is subretinal and how much is sub-RP, what is the height at fovea. All those things actually play a very important role in deciding the prognosis as well as management. Now, I think this is a very simplified three-prong, I think, approach. Like, if the blood is not much, I think we are mainly focused on etiology, and we try to treat whether it is RAM or it's MNV. But if it is significant and within arcade, then we can always go for pneumatic displacement. And very selected cases actually require subretinal TPA. Most patients do very well with pneumatic displacement itself, as I'll show in subsequent slides. And if it is really massive, then either you can go for multiple drainage retinotomies or for a more radical approach where you induce giant retinal tear and remove that massive subretinal blood. Now, most of these patients have a very acute presentation. So this is again very important that they come to your OPD and there is sudden vision loss, and they are quite anxious. So when we are managing them, this again is very important. We don't want to delay the management, not only because that heme is toxic to fovea. I think they are quite disturbed also. Now, this I have already discussed. Either we can drain or displace it. I think this was a very remarkable paper presented at one of the retina meetings by Heriot, where he first described this pneumatic displacement. And all of us have started doing it, I think more than now, almost 2 decades back. And just few early cases where we didn't have much of OCT. We were mainly relying on fundus picture. This was post-traumatic submacular hemorrhage. And you see we injected gas. You can see a shadow here from gas bubble. And if you see the overall, the size of the blood was very not that big, but you get to know the amount of blood when once you see it getting displaced inferior temporally. Now you see this much amount of heme was lying at macula. So you displace it. I think you save all this clotted blood from accumulating at macula, and very good example to show that there can be a choroidal rupture underlying. So when we are explaining prognosis to these patients, it has to be guarded unless you're very sure that fovea is not affected by choroidal rupture. But this was probably one of the most interesting case which actually changed my approach to manage these submacular hemorrhages. This was almost a 1 month old large submacular hemorrhage, and this lady insisted that do something. And those days we were not doing too much of subretinal injections. So I said, okay, I'll be as a trial, I will give you gas and you maintain prone position and let's see what happens. And we did same thing, but you see the size of the gas bubble, right? It is actually a really large size gas bubble which we used in this patient. And 2 days after injection, you can see the significant displacement of blood. And then obviously she kept improving. And another thing which I noticed in this case was that displacement kept on happening every week. And that's the reason you try to use longer acting gas in these large sized submacular hemorrhages. And obviously then we treated her CNVM also. So that actually also tells us that it's never too late. If you have a patient who can't afford surgery or TPA, giving pneumatic displacement as a trial is also a very good option. And I am a very strong advocate of using gas alone as a primary treatment for most patients. And these are the main reasons. The biggest reason is that it's always available with us. You don't have to arrange for it, and you can inject same day as a first aid, make them lie prone in your OPD, and see them next day. And believe me, it will do the job for most small and majority of larger submacular hemorrhages. On the other hand, intravitreal TPA, actually it invites cost and all those approvals if patient is insured. And also, I think literature is still equivocal on its efficacy. Subretinal TPA definitely works significantly well, but amount of displacement you get with or without intravitreal TPA, because most studies they still use pneumatic displacement with intravitreal TPA. So how much difference it makes is still needs to be proven. And the most important reason why I hesitate to give intravitreal TPA is that you can always go for stepwise approach, go for pneumatic displacement as first line. And if after a week you feel it's not working, you can always go for either vitrectomy with subretinal TPA, or if you still want to give it a try, you can give intravitreal TPA in a gas-filled eye also. So that's a very good stepwise and financially better approach for patients. The another thing which I wanted to highlight was why I'm saying gas alone is even anti-VEGFs also, like a lot of our fellows are now very fond of answering that why not go for cocktail regime and give all three, gas, TPA and anti-VEGF. Theoretically, at least anti-VEGFs are less likely to penetrate larger clots which are surrounding the choroidal neovascular membrane. Why C3F8? I have already highlighted that shifting is not one-time affair. It keeps shifting, and if there is large amount of blood, I think longer acting gas works very well. If you have a one-eyed patient who is disturbed by that bubble, anyway, you are going to inject anti-VEGF after a week or 10 days. So in that scenario, you can always tap it if you need to get rid of gas. If it has done its job, you can tap it. Now, just few cases. This patient was Westin for really long term in right eye, and then he lands up with gas, submacular hemorrhage. We injected gas, and it shifted, and then he came with another round of hemorrhage. We again injected gas alone. the blood shifted nicely, and then he came with massive submacular hemorrhage. At that point, we actually, I don't have the videos for this patient, but we used this subretinal TPA. So again, this case I shared to just, I think, share that this bleeding can happen multiple times also. So what works well for primary hemorrhage, I think will work for secondary hemorrhage also. You can still go ahead with gas. And this is a very nice case which highlights the role of OCT. Now, if you see this patient's vision has dropped to just 6/60, looks like a very small amount of heme at fovea. But when you cut OCT scan at fovea, you can see significant height of heme underneath fovea. And so we injected gas. Again, you can see a nice size of air bubble and the blood getting displaced. And even I think at 1 week, you can see this blood getting displaced nicely. And you can see this organized blood. So we could prevent this happening at fovea. This case, again, a very interesting case, PCV with subretinal hemorrhage, not involving fovea. You can see only serous fluid at fovea. And we were planning ICG, and then lady comes back with another round of bleeding within a week. And you can see this fresh blood coming from polyp. And now you can see the difference between subretinal serous fluid and subretinal heme. And that was the time when we, there was a polyp also, but we injected gas and shifted blood and then treated polyp with laser. And many of these polyp patients have foveal thinning also. And this is very interesting finding. Earlier, we used to think it's PDT induced, but now we see a lot of our polyp patients who are treated with anti-VEGF, they also have foveal thinning. I think I'll skip. Yeah. So another thing I think which is very important when we are managing these submacular hemorrhages is that we need to have a very large bubble and on table itself. So that's the reason we try to use isoexpensile gas for this pneumatic displacement. So what we do is like we take if we are using C3F8, we take around 0.2 and make it 1 so that it gets nicely diluted, and we try to give 0.4 or 0.5 ml of big gas bubble. And so I think I'll just show this in one of the patients. Again, it looks like a not very big size hemorrhage, but you can see on OCT both sub-RP and subretinal heme. And I'll just quickly run to show that how to achieve a large size bubble. All of you know that how to do is. So when I am injecting, my needle is not 100% in. The moment you see a bubble, just try to withdraw the needle and keep injecting in the bubble itself. Now I'm checking the light perception, and it was really large size bubble. This we do very rarely. Even if after a couple of paracentesis you feel that pressure is not coming down, you can actually tap the bubble itself. So, and you can see with this bubble, the theme shifting nicely, and at 2 days itself, significant shifting happening. And when you do this photography, you can always judge the size of bubble by the meniscus. And so I think I will conclude by saying that pneumatic displacement by gas alone is actually very underrated procedure for submacular hemorrhage. And the biggest advantage is that it's immediately available, low cost, and you can always do additional interventions subsequently if required. Thank you.
Thank you, sir. So very intriguing concept here. You're bringing in a couple of things which before we get back to our main discussion, one thing which we would want to discuss with Dr. Vishnu's case is it's a RAM case. So as you showed that if we actually have a submacular hemorrhage, so do you actually consider the morphology as a whole if it's a more clotted blood? As you showed it in one case, where it was more than a month. So when do you actually decide whether you want to go in for a TPA or a pneumatic displacement? depending upon the morphology, if it is a old clotted blood, or maybe it is like becoming like more organized, the whitish thing which is coming. And with respect to Dr. Vishnu's case, I would want to ask whether if it's a RAM, so do you want to laser that thing introp as well, or you would want to do it in a next, or maybe subsequently you would want to do it? And whether you would want to, there was a question from in the chats where they are asking whether to use anti-VEGFs for a patient who has a RAM. So do you go for anti-VEGFs for that?
I think great question. So I'll take up, I think the anti-VEGF one first. Anti-VEGF only if I see a lot of hard exudates and I see that too much exudation has happened, there sometimes we give. But if it is only serous detachment involving macula, very few exudates, I think there is not much role of pre-operative anti-VEGF for these patients. You laser the RAM and displace the blood. I think it resolves very nicely. I'll show a couple of cases in second session about that. If preferably you should try to do laser for RAM intra-op only. So because it keeps growing. Earlier, we used to think that it gets ruptured and the story ends, but no, I think it still can start growing. So and it's easier to laser it intra-op. So I think it's more easier and more precisely you can do the laser. And what was your first question?
So whether you would see the morphology directly and then decide for the surgery, or you'll give a try of pneumatic displacement and then sequentially you would want to go switch into TPA or added anti-VEGF, or maybe do a vitrectomy followed by that.
I think in morphology, yes, but what we try to assess is one is duration. If there is a clear-cut duration beyond 1 month, then probably it's better to go for surgery and inject subretinal TPA. Second is you have to see how much heme is lying superior and nasal to fovea. Because when we try to displace it with gas alone, it almost always goes temporally and downwards. So if you have a big heme where edge is at the fovea, you would not like to displace it by gas only, because even if you displace it significantly, still larger portion can still end up being subfoveal. But otherwise, it's very difficult to judge the clotting behavior of submacular blood on OCT. So that's it.
Thank you, sir. I think we'll get back to our presentations. We'll have Dr. Neha Mohan. Madam, she would be presenting a case. Dr. Neha Mohan is currently, Dr. Neha Mohan, you're there. Can you share your slides, please?
Yeah, I'm sharing.
Yeah, thank you. So Dr. Neha Mohan here is currently the VR and UVR consultant at Jain Eye Hospitals and Laser Center at Shalimar Bagh, New Delhi. And she did her long-term fellowship in Vitro-Retina at LVPI, Hyderabad. So over to you, Dr. Neha.
Yeah, can you see the slides?
Yes.
Okay. So as the topic says, it's almost a decade follow-up of a case of PCV, and we had a 75-year-old female who is a gynecologist by profession. So she started showing me in 2016, and she was already a diagnosed case of PCV for more than 5 years, and she had taken multiple sessions of PTT by then. And left eye had bled massively a few years back, for which vitrectomy was done, but she never regained her vision. It was a pre-thusical eye, and PL was negative. The right eye had also underwent vitrectomy for a massive bleed, and the vision was 680 with me. Now she was done with the PDT thing and she wanted monotherapy. So we started doing monotherapy for her. So this is like the first picture that I have with me of June 2017. And we can see temporally it's always been bleeding more, and just temporal to the fovea, that submacular heme would always concern me because it was just near the fovea. And we can also see in the OCT that here we have that mound temporal to the fovea with the subretinal heme. So we started off with the biosimilars. Sometimes we would give razumab, sometimes eccentrics. But as we see in the follow-up, like in June 2020, we see the SRF would come and the PED would always be tented like this. Although all the time she was maintaining a vision of 618. And after a few years of eccentrics and Razumab, we actually shifted to Eylea. Sometimes we would get a flat fovea and sometimes we would have our cysts back. But if you see constantly, the temporal elevation and the temporal heme subretinal was always there and would always, make me unsure that one day it is going to massively bleed and I don't know what I'm going to do. So in Jan 2023, we actually shifted her to Pagenex because I would see some cystic spaces always at the fovea, which would make me uncomfortable. And as we started her on Pagenex, we started getting a better response. And somehow we were giving her the injections every 12 weekly, but she decided to miss her November dosing because, it's a lot of load on the patient to take these injections for years and years and years. And then she came with this. So if we see temporally where the white arrowhead is, there was a massive bleed and that was tracking down to the fovea. The vision had dropped to finger counting 1 meter, and because she was one-eyed, she was really nervous, and it was already a vitrectomized eye. So we went ahead with the surgery itself, just did a fluid air displacement, and we used SF6 gas and gave her a face down position along with the Pagenex. And she started doing better. Here we can see the gas bubble slowly going, and these are the eventual follow-ups. So in May 2024, the vision started improving, then July, and now we were giving 12 weekly injections. And this is the last follow-up in January 2025. And the vision has restored back to 618. But the best thing is that the temporal elevation and the temporal subretinal heme has actually now gone. And this is how the OCT looks. The temporal elevation has also gone. And we have almost given 4 injections last year, and the next one is due. So this is the entire follow-up and the entire history of the patient. The highlights of my case is like, it's a real long follow-up, so you can never give up on these guys. And continuous motivation is very important to take the injections when you know that, the disease is active. And I somehow feel the anti-VEGFs act in a vitrectomized eye, and I want actually an explanation that how their half-life is not affected and why we don't have to reduce the dose or something. And it's a message basically that they cannot miss their treatment. It has to be like at least 12 weekly, and we cannot go beyond that. Thank you.
Thank you, Dr. Neha. Great case. Can we have Dr. Deepak, and then we can club the questions for these 2 cases together?
Yeah,
So,
sure. Avnish, can you hear me? I just want feedback.
Yeah, you are audible. Dr. Deepak Bhojwani is a VR consultant at Bhojwani Eye Hospital and Retina Center at Ahmedabad. He has done his long-term fellowship from Shankar Netralaya, Chennai, and his pediatric retina fellowship from LMU Munich, Germany. Over to you, Dr. Deepak, and from here we can pick up.
Thanks, Avnish, for a formal introduction. So I'll be sharing few of my experiences with submacular hemorrhage. So as we all know, submacular hemorrhages are not easy cases to handle. I'll share a few of my early experiences. This is one of the first case which I had experience with massive submacular hemorrhage, one of the earliest intervention, surgical intervention, which I'm going to share. So case background, she is a basically one-eyed patient, aged lady with a massive submacular hemorrhage. Here you can see the hemorrhage is extending beyond the arcade. It's more than 10 disc diopters. So after detailed counseling, I counseled her for surgical intervention, and the plan is vitrectomy associated with subretinal cocktail. So whenever you are planning vitrectomy in such cases, the first thing when you are doing any retinal surgery is first to get rid of vitreous to induce a PVD. So whenever you are inducing a PVD in such case, your target is posterior pole. So whenever you see any lesion in the periphery, don't be expressive to get do an extensive peripheral vitrectomy. Just cut the vitreous and leave it alone. So once the core vitrectomy and the vitreous is gone, now your focus is on posterior pole. So here is a subretinal cannula. This is 39 gauge subretinal cannula. So I'm first going to inject and make a dimple on the retinal surface once I see the fluid is, the cannula is working and the fluid is going on, you can see the stream of it. I'll go down on the retinal surface, make a dimple and inject subretinal TPA first. Once the TPA, the dose of TPA which I have used in this case is 25 microgram. After inducing TPA, I usually wait for around 5 to 8 minutes for clot lysis to happen. This is followed by a subretinal Avastin, the standard dose 0.1 ml, which we commonly use in a case. So, and lastly, and I'll inject a subretinal air. So all these cocktail, what they happen to do is all three things. So whenever you inject anything in the subretinal space, there will be dilution of all the toxic products, first thing. Second thing is displacement. They are going to displace the blood inferiorly. And the third thing is the pharmacological action. So TPA is known for doing clot lysis. The clot lysis will happen. And the anti-VEGF, like any Avastin, which is used in this case, will tackle the primary pathology. And because the dose, because I was treating a massive case, so there was enough space to inject air also, because I wasn't sure whether plan to maintain a prone position post-operatively. So this was my thought for using subretinal air. So here you can see the mounts of air and you can see nice blebs inside. So whenever there's a I feel the patient is non-compliant, I intraoperatively use a subretinal air to make sure I can displace the heme and see the behavior of the macular hemorrhage intraoperatively. So usually this is followed by a partial bleed. You do not want to pressurize the compartment. So here you can see the blood is cleared, but some blood is there. I will come back to you. So post-operatively, in 1 week, the patient has started gaining, and you can see the meniscus of the gas. On 1 month, the patient has improved the region. And on OCT, I want to highlight you is, you have, whenever you are dealing with submacular cases, there are two components which you should be worried about. One is subretinal hemorrhage. You can always displace subretinal hemorrhage, but a sub-RP hemorrhage, you won't be able to displace it. So whenever you have primarily a sub-RP hemorrhage, this technique of displacement, pneumatic displacement, may not work. The pneumatic displacement usually works when it's predominantly a subretinal hemorrhage. So in postoperatively, here you see the fovea has gone down, and you can see a nicely foveal contour. But these surgical interventions, they have complications, they are expensive, and they require a massive, because these patients are aged, they need a physical fitness for using subretinal TPA also. So most of the patients may not be affording these expenses. So what other choices do we have? So this second case was an eye opener for me. So this is an aged lady, 68 years lady. She's a relative of my OT staff. She comes to me with, coincidentally, she has noticed poor vision, which is more than for 1 month. So for 1 month, she's been having this massive bleeds in her eyes, but she's reluctant for any surgical intervention. So I told her that we will not do any surgical intervention. We'll do just a pneumatic displacement just to see how this hemorrhage is going to work. So at one week post-op, you can see the gas meniscus is there, and the heme has started clearing, and also she has started getting vision. At 1 week, she was 660. At 1 week, because she had promising results, she continued with anti-VEGF injections. So I gave her monthly injection. This is the picture what we see at 3 months, after 3 loading doses of Avastin only after 3 months. So now you see the point I want to highlight is here the pneumatic displacement works very nicely even in for chronic submacular hemorrhage. So you should always give it a trial of it. And regarding anti-VEGF agents, it's not necessary that submacular hemorrhage is due to PCV and you need to use only higher end anti-VEGF agents like ILE or Pagenex. Even Avastin can also work if the patient is not affording. So you should always give a trial. So here the main thing in submacular hemorrhage, the one thing you should remember is displacement of hemorrhage is very important. Once the blood is displaced from the fovea, usually the patients get a vision. So my current approach, whenever I see a massive macular hemorrhage, is pneumatic displacement. So whenever there's pneumatic, usually I use a C3F8 gas, which is long lasting, like Deependra sir told, and this is how I get results within a week or a month. But the most end of the story is CITAS patients, usually after treating them with surgical intervention, the story doesn't end. So usually these patients should be told that you might need repeated anti-VEGF injections to clear up the primary pathology once the macular bleed is gone. Thank you very much for your patient listening.
Thank you, Dr. Deepak. And can we ask Dr. Deependra sir for the first case which Dr. Neha explained about? So what would be the possible cause for the breakthrough heme which actually happened? Was it the treatment which was not happening, or it was eventually because of the PD it actually gave away and it eventually happened? Or does there was possibly a rip or something which happened with subsequent treatment with anti-VEGFs? So your take on that case?
I think, Dr. Avnish, all of these are possible. You have nicely highlighted what all can lead to this kind of bleeds. But with this phenomena is quite there. The moment you try to increase the duration of injections, duration between injections, or patient skips the dose, I think they come back with bleed. But contrary is also true. I have seen bleeds happening with even strongest agents within 2 weeks of injection, probably when they are at their best. So it's like an accident. I think it's very difficult to comment upon that what led to that bleed. The CNVM is growing, it's encroaching vessels, and uh, so and breakthrough normally happens wherever there is retinal thinning, and it can be at the summit of PED or the other points. I think if we can do a raster over whole area, we can find out, but it doesn't help much in our decision making. It's actually it's luck. If we are lucky, it will not cut through for RP rip will not cut through fovea. So
One of the things which Dr. Bhojwani as well as Dr. Vishnu has shown us about that large macular submacular heme. So when you're doing a TPA, what is the specific area you target so that the effect of the cocktail or maybe only the TPA is maximum? And secondly, for the viewers, can you tell us the dosage and the dilution technique which is used, and how do you actually deliver the TPA? So, as we had discussed, whether are you using it foot pedal controlled or you're using it manually, and what sort of syringe are you using?
I think it's very simple when you are using TPA. You mix the both vials, and I think you get the desired concentration. It used to be 25 micrograms. Initially, people were using 50 micrograms when they were injecting intravitreal. And I think in the concentration which is available after you mix the two vials, the liquid and the powder part, you get exactly the concentration you want to use. Now, this question is very has been discussed quite frequently, that how much is safe to be injected in subretinal space. In general, we whatever comes out of your retinotomy anyway gets washed off. So the dose actually is you judge by seeing the size of bleb, right? So what I try to do is, if I am dealing with a large submacular hemorrhage and if I have injected and made a large bleb, after, just like Dr. Deepak said, I'd like to wait for some time, and in those patients, sometimes I try to aspirate also, and with the same 41 gauge needle and kind of wash kind of thing, so that I'm not leaving too much of TPA in some macular space at the end. All right. But overall dose which can be delivered safely in subretinal space is nobody knows. But that concentration is quite retina friendly, and we have never seen any major toxicity happening. I think injection by hand is much more controlled because your reflex time is shorter. And only challenge is 1 ml syringes are really longer ones. I was discussing with one of my colleagues that if we can get shorter 1 ml syringes, the size of syringe should be like we have 2 ml syringe. Then probably injection by hand, because it gives you a nice feedback so that you can increase or decrease the pressure. And especially if you are reusing your 41 gauge cannulas. All right. For a fresh cannula, 3-4 psi on Constellation is fine. But sometimes when you are reusing, I think you need to increase, and that is the time foveal blowout happens. I'll show one case where it happened actually.
So yes, coming to that, we can have your second set of presentations, and then we'll take it from there, sir.
So I'll quickly, I think, show two cases. I think, and both were, I think, injection was done with different techniques. This is very classical RAM. I think Dr. Todi has very nicely shown, and the best part I liked in his video was that ILM was very nicely removed by cutter itself instead of peeling. So this was again just to show that you can also peel ILM over the sub-ILM bleed in cases like this. And I'm sorry. Normally, what we try to do is at the intended site of subretinal injection, we make sure we peel ILM at least at that part. Now choosing which place we should be injecting subretinal TPA, I think you should try to injure lesser nerve fiber layers, so you can't go very close to disc. And whichever part you try to make bleb, you have to ensure that ultimately you are injecting TPA to involve whole amount of blood, and you can see, so you can always choose your site where the maximum height of blood is there. And it you go to disc, you are made more. I was telling that here I got a really big bleb, so I'm aspirating also at the end. And you can see now this was a case where I didn't laser the RAM, and that's why I wanted to show this case. And you can see it looks very nice at 3 weeks follow-up, and then you see what happens. The RAM starts growing, and actually on serial OCTs you can see intraretinal edema coming back. And at that point, then we did laser post-operatively, and finally it regressed. So I think from this case, I learned that better to finish the job inside OT itself. And then I think this patient has completed now more than 10 years follow. This is again a very interesting patient with lasered BRVO. He has been following up with us for quite some time. And you can see the foveal thinning even before he developed subretinal hemorrhage, which we have not noticed. And then he comes with this RAM and hemorrhage, and you can see significant submacular fluid and some hard exudates also. So this was a patient where we gave preoperative intravitreal anti-VEGF also. And you can see this foveal thinning, and these are all high-risk cases. And you see what happens. And this is the patient where I also used automated injection of subretinal TPA. And as a rule, we try to peel ILM first before subretinal injection, because things are quite controlled and clear. So I made sure I am removing all the ILM, and which I'll repent later. Now again, I am trying to inject away from disc and at the place where you have maximum height. And I don't know, Dr. Avnish, could you notice the fluid coming out of fovea? Let me show it once again. There. I'm not sure whether video transmission is good enough.
No, we can see Dr. Deependra. Avnish will join back in a minute or so. I'm Dr. Bhavik here. We can see it here.
So somehow I caught hold of some floating ILM in vitreous cavity, and maybe it was lucky day for patients, so I could place a small flap over fovea, and you can see it's lying there in post-op period. So that's why I said I think these all points have been discussed very well, but I think if you have a foveal thinning and you need to be more careful, you can actually inject at multiple places and create smaller blebs in these patients. If paying attention to foveal thickness is also important when you are assessing these patients. And this patient was actually having submacular hemorrhage in PDR eye, and he was on dialysis, and he was operated vitrectomized eye long back, and then he landed up with this submacular hemorrhage. So I knew his positioning may not be, he may not be that compliant with positioning. So again, Dr. Todi was very nicely telling that, Dr. Deepak was telling that make a dimple and then enter subretinal space and inject. And I injected some air also, and you can see significant displacement happening with this. So couple of cases I'll show that even if you encounter with massive hemorrhage,
So he was
you
a
need not
74-year female who
you need not go for complete drainage also. And this was a really massive subretinal hemorrhage, but you see fovea was nicely spared. And I was thinking of doing a very radical surgery in this patient, but when I saw that macula is spared, I decided we'll not be doing anything. And you can see Only thing is, doing fluid air exchange, these all mounts, they started migrating posteriorly. So I thought, let me give it a try, drain it from external side. But again, just like suprachoroidal, probably it was clotted and it didn't drain much. And this lady had a history of macular hole surgery in fellow eye. And you can see first 4 weeks, she was absolutely fine and vision also 6/12. And then she came back and we were actually trying to do imaging to find out the etiology for such a massive hemorrhage. And I was worried about metastasis. But then she came back with macular hole in this eye, same eye. So we finally did the ILM peeling, and now you can see organized blood all around. Even at this point, I was just contemplating that should I also inject subretinal TPA, but again, when I saw that macula is not involved, just did the ILM peeling and she closed very nicely. And you can see a hole also closing, and it turned out to be a large polypoidal kind of lesion nasally. And once it was leaking on ICG, we just did laser. Of course, we did a thorough systemic evaluation to rule out any primary. So idea is that even if you see massive subretinal hemorrhage, I think what matters is how much is that macula or fovea itself. And again, the similar patient, massive subretinal hemorrhage, and this patient also, we were thinking that we'll do a much more radical surgery, but he became very uncooperative. And you see, I'm trying to remove posterior highlight, and within 15 minutes of surgery, he became quite uncooperative. So quickly, what we did was 4-quadrant retinotomy, one hair, and PFCL, and you can see, I think there's a lot of shaking happening because my assistants were holding his head, and just 4-quadrant retinotomies and drained as much as possible. You can see the mounts still there. And you see this patient at 6 weeks follow-up, maintaining 6/12 vision, and I think doing quite well. Now, the one point which we were discussing, that if your pneumatic fails, then what? So I think this is an example where we tried pneumatic, it didn't work. So now going for surgery. And this case, again, I wanted to show that sometimes you are dealing with a case like this, where you have a central scar, some part of blood is organized. So here what we try to do is we try to inject in the area where you have heme, non-organized heme. I think TPA is going to flow easily in that area where you can still see liquefied heme rather than injecting over organized heme. And again, here you can inject at multiple places. And our whole purpose is to get this area clear of blood, because this patient was almost 5/60, 6/60 before bleeding happened. So again, you can see blood shifting temporally and downwards. And on OCT also, you see this significant subretinal bleed shifting. So I think I'd like to conclude here that our main target is to get rid of blood from macula or fovea. So that's why we do very less radical surgeries for massive hemorrhages. We just try to clear macula, of blood, and I think other points I have already discussed. Thank you.
Thank you so much, Dr. Deependra, for the wonderful insights into such cases. Before we move on to the next presentation, I have a question for you. Then the question is, when do you consider doing retinotomies for draining the subretinal blood? Like, is it in all cases, or if it's just inferior, is it the age of the hemorrhage?
I think retinotomy only works if liquefied blood is there. And I was trying to analyze this also. I think suprachoroidal and intravitreal blood is fastest to clot. But surprisingly, sub-ILM blood and sub-highlight, it stays liquefied for almost ever. Subretinal blood, actually, in journal, I have seen it also doesn't clot. that easily. So first 4 weeks is the window period. And once it starts getting organized, then it's very difficult to be extracted. So, but on the best part is there is no harm in giving it a try. But we have had circumstances where it was cheesy and organized kind of blood when you make a retinotomy. Those are the cases probably where you have to induce a GRT and do a much more radical surgery. The case I have shown, you can see the retina was quite bullous, and you can make out that it's a liquefied dark colored blood. But timeline of subretinal bleed has not been described well in literature. That till what time it is liquefied and then when it gets organized.
Thank you, sir, and thank you, Dr. Bhavik, for the backup. So I would want Dr. Ravin Punamia to actually present his case now. Dr. Punamia is a fellow, long-term fellow at Joshi Eye Hospitals at Hubli, and he did his primary DNB from Choitram, Nepal, India. So, Dr. Ravin, if you can please share your slide.
Am I audible?
Yes, please.
Thank you so much for that introduction, Uni sir. Good evening, everyone. So I'll be presenting an interesting case. A 75-year-old male, he came to us with complaints of diminution of vision in the right eye since 10 days, which was associated with metamorphopsia. There was no systemic history, but there was history of multiple anti-VEGF injections being given for polybodal choroidal vasculopathy in the same eye. On presentation, he had visual acuity of 1/60 with the anterior segment normal, fundus showing a subretinal hemorrhage over the macula, which was obscuring the fovea with subretinal fluid as well. And OCT showed tall hemorrhagic PEDs with subretinal hemorrhage as well. So diagnosis of PCV with subretinal hemorrhage was made. And unfortunately, the patient was not willing for a surgical intervention. So we advised intravitreal brolucizumab injection, following which there was a reduction in the height of the PED, but the submacular hemorrhage was still the same. So we decided to go ahead with pneumatic displacement. Post pneumatic displacement, we saw that the PED height had reduced and the blood had started getting dehemoglobinized and also started organizing. So we decided to go ahead with a surgical intervention instead. And we performed a pars plana vitrectomy. Along with that, IVT assisted PVD was induced. And with a 41 gauge cannula assisted, automated viscous fluid injector was used, and subretinal TPA with fluorescein tag TPA was used. The fluorescein helped us to visualize the size of the site of the injection. It helped us to know the correct plane. We were forming the plane. The injection was going in the right plane. It helped us to see the area of diffusion, and it also pointed out to us the sites of leakages from where it was refluxing back into the vitreous cavity. As is visible here from the previous site, it's leaking back. Following this, we did a fluid air exchange, and SF6 tamponade was used. So under air, we can see the subretinal space stained with fluorescein, showing the area of spread of the dye. So this was 2 weeks post injection, and the patient presented. The visual acuity had improved to 6/36. There was organized clot, which was juxtafoveal, and there was resolving subretinal hemorrhage. And the OCT also showed near resolution of the PED and subretinal hemorrhage. And this was 3 weeks later. The vision improved further to 6/24, and there was further resolution of subretinal hemorrhage. So here you can see how it progressed from on presentation to post surgery. There was a resolution and the visual acuity improving from 1/60 at presentation to 6/24. So I had some certain points that I would like to discuss with the esteemed panel. Like, should we, in this case, we did anti-VEGF followed by gas injection, but is it better to try gas first and then do the anti-VEGF? Or as I said before, if a combined cocktail is better? And what would be the ideal outcome post pneumatic displacement, and when can we say that it has failed and surgery needs to be done? And if anyone else has any personal experience with fluorescein tagged subretinal TPA. Thank you.
Thank you, Dr. Ravan. Can you please keep your questions slide?
Yeah.
So over to you, Dr. Deependra sir, if you can highlight and discuss all these points.
Doctor, audible?
Yes, sir.
Yeah, I think very good questions. First one I have already, I think, addressed in my first presentation that in general, I try to give gas on the same day. So almost always I inject gas first and manage the pathology subsequently. Anyway, we are going to see these patients at least next day and after at least after a week. So they are coming to us. So there is no hurry to treat the CNVM. And we can always give it after 1 week with all necessary approvals, and logistically also it's easy. So I don't want to delay the gas so that's why that's my go-to approach. I think this is a very interesting point that how should we judge the displacement? When we were trying to compare few years back, we actually thought let's do it much more objectively and capture the blood displacement from the upper edge of the heme, that how much it gets displaced. And now we have wide field OCTs also, but so far I don't think there is any study which has one couple of studies did it on fundus photographs, but it would be very interesting to compare amount of displacement between two groups, with or without TPA or maybe subretinal TPA, so that you actually get an idea that what should be the displacement, which treatment is more effective. But practically speaking, if your fovea is off blood, your job is done. The end point of your displacement is your fovea getting rid of blood. I think this fluorescein tagged TPA, we had this in our DRF winter meeting also. So the presenters, the only question I asked them was, can fluorescein interfere with the TPA's action? We need to confirm that, number one, because whole idea of injecting TPA is to lyse the blood, and fluorescein is notorious. It interferes with lot of blood testing. Rather, when we were doing a lot of FFAs, we used to ask patients not to go for blood testing for next 48 to 72 hours because it can interfere with your blood testing. Right. And those days it was typical. Patient comes, PDR patient comes, you do FA and you write investigations, and they will go next day, and their results would be flawed. So I'm not sure whether fluorescein interacts with TPA. Second, Dr. MPS asked a very pertinent question that what do we gain by visualizing subretinal TPA, which is tagged? But I see fine. I think it's nice that you see fluorescent subretinal collection, but ultimately whatever you have injected, you are not able to titrate anything, or none of your, it doesn't let you know your endpoint of injection also. So my point on the fluorescein tag TPA is this.
Thank you, sir.
Thank you so much, sir. We'll like to call upon Dr. Harshita here, if she's around and she can share her slides. Dr. Harshita?
Yeah, good evening, sir. I'll just
Yeah, please. So this is the last case, and then we'll try to summarize what we have learned from the...
my screen is visible.
Yes.
Yeah, the slides are moving, right? Good evening, everyone. I'd like to present an interesting case, which I titled as A Story That Keeps Bleeding. So a 66-year-old male patient came to us with a diminution of vision in the left eye since 2 weeks. Presenting visual acuity was 6/75 in the right eye, left eye had 6/30. So he was already a diagnosed case of PCV in the right eye, and he had a scarred CNVM. But this time around, he had presented with a diminution of vision in the left eye. So on presentation, we saw that there was a large bleed which was noted. So there was a subretinal hemorrhage with PD with SRF. So these are just the pictures of the patient from his previous follow-ups. As I said, right eye had PCV and right eye already had a history of having intravitreal IVTA with the ranibizumab and gas injection for a submacular bleed. Now, at presentation, the right eye had a scarring, as I already mentioned, whereas the left eye, there was a significant subretinal bleed at the fovea, along with fluid and a PED, which you can see temporal nasal to the fovea. So we diagnosed him as both to have both eye PCV and planned a left eye intravitreal injection along with the intravitreal TPA and SF6 gas injection. So the patient was stable post-op day 1. You can see here there's about 20% gas which is visible, and the subretinal blood also displaced into the inferotemporal quadrant, as sir was telling, and there was a PD at the fovea. Now at post-op day 7, again, the subfoveal hemorrhages were displaced or shifted more to the inferotemporal quadrant, and we had a small area where we thought that there was a rip in the temporal RP rip in the temporal area. But the SRF appeared resolving and a small gas bubble still remained. So at this stage, we decided to repeat the razumab injection to treat the primary pathology. Now, post 1 week of ranibizumab, what we noticed is that the patient had a rebleed with the retinal hemorrhages involving the macula and extending significantly temporally. So at this stage, we decided to repeat intravitreal TPA and give gas injection to repeat SF6 gas along with tapping the previous gas a little bit. Patient was stable post-op day 1 again, 10% gas fill as is noted in the picture, and the hemorrhages again migrated away from the fovea and the OCT showed decreasing SRF. Now 1 week post-op, as the previous time, resolution of hemorrhages is noted and a small gas bubble is still remaining with PD and RP changes at the fovea. At this stage, we also decided to get a systemic evaluation done for the patient since he had bled for the second time. So on systemic evaluation, we noted that he had thrombocytopenia with a platelet count of about 90,000. Now, what happened 1 month post-op after the second TPA injection is the patient had a massive increase in subretinal hemorrhages and fluid as compared to the last visits. So we thought that at this stage, let's dig deeper and take a hematologist opinion, as in why is the patient bleeding again and again, and whether it's an ocular cause or a systemic cause which is responsible here. So to our surprise, systemically, all his examination was normal. The coagulation profile was okay, and the blood parameters were all fine. Now, then we decided what next, as in should we be treating, the patient was very reluctant for surgery before this, but at this stage we explained and told him that he has to undergo surgery, and we planned for a left eye vitrectomy and this time around subretinal TPA with the oil and anti-VEGF injection, and the patient is yet to come back for follow-up after surgery, so we'll be following him up later on. So now my questions to the esteemed panel here are, what do you think could be the causes of the patient bleeding several times over such a short span? Could it be systemic versus ocular? Secondly, what is the experience, sir, you might have with repeat TPA injections? As in, how many times can you give them and with how much gap in between? And also management-wise, what could have been done differently during the course of treatment, according to you, which probably would have led to a different outcome? Thank you.
Thank you, Dr. Harshita, and quite a different case, and somehow we'll see how the outcomes would be. Over to you, Dr. Deependra, sir, if you can address these questions.
I think whenever you get this recurrent submacular hemorrhages, even in MNVs and even in diabetics, I think correlation with systemic anticoagulants or systemic hemostasis is very less. It has always been investigated and results have been negative. even CAT trial, and most of these post hoc analysis, they have tried to associate that with and check whether this bleeding is related to systemic uh, uh, coagulation profile, but it never came positive. So it's actually a local bleeding which happens from growing MNV, and I think all of them are chance incidents according to me. Maybe the lot of vessels were exposed, and as MNV grew in the wrong direction. They are highly unpredictable. Just a few minutes back, I was highlighting that you can get it even after strongest injection also within 2 weeks. And only thing, and you have done very well on maybe when you were trying to change the anti-VEGF, one can go for a more potent anti-VEGF. And as far as TPA injections, I think half-life is so short, you can always repeat it. If you like patient gets massive hemorrhage, uh, and then anyway it will be a vitrectomized eye second time. So you are not worried about toxicity and other things. And silicone oil was also, I think, right choice, because if patient has tendency for recurrences, oil will at least keep retina attached, and it will allow you to see the lesions, do the imaging. So I think you have done very well. I think there is a question that can we repeat anti-VEGF after a week? I think we can always repeat it. What additional benefit you get is question mark, because double dose, and nowadays they are saying 4 time doses of and even for Avastin, double dose was found to be equally safe. Many of us were actually giving double dose. Eyelia everybody is giving. So and if you are repeating after a week, it is not even double dose. It's lesser than, because maximum part would have washed off. Only thing differently we could have done is maybe go for a stronger anti-VEGF like brolucizumab or this.
Yeah. So the moment we thought that we'll switch over to a different anti-VEGF, the patient comes back with a rebleed. So we were thinking, whether to switch now or once the bleeding settles.
No, this happens. I think the case I have shown, which bled third time, I have seen his own son was a senior scientist in Genentech, and that's why he was taking Avastin, because he knew in US that those days there were only two anti-VEGF, Lucentis and Avastin. So he was sticking to Avastin throughout, because even Genentech engineers were convinced that the molecule is as good as ranibizumab.
Thank you, sir.
Thank you, sir.
So for this, so how do you actually go about with patients who have actually had a very good displacement and they come back with 3 bleeds? So how frequently do you want to follow it up? Or else, post successful outcomes of your pneumatic displacement, or when you use the TPA, so how do you actually follow up these patients?
I think we need to, yes, definitely call them very frequently, much more frequently than they were coming. 4 weeks makes a lot of sense, and especially depending on the anti-VEGF now you are using. And I would definitely like to do ICGs more for these patients and rule out peripheral polyps. And I think lasering those definitely helps. It can reduce the recurrences. But if it is a BVN or large MNVs, then there is not much you can do. You can always ask them, you can counsel them that this can happen. All you have to do is come back immediately and come prepared for gas injection. And that's how we do. We tell them that, and and also we tell them that if it is like massive, we'll go for vitreous surgery. So better counseling, closer follow-ups. That's it.
Thank you so much. So, as a whole, like if your first line of management for a submacular hemorrhage would be a pneumatic displacement, and from there you will take it up after a week as to how it is moving ahead. So once the fovea is kind of moved off the hemorrhage, you would possibly want to follow it up. And subsequently, if you want to use a combining adjuvant like a anti-VEGF or a TPA, that would be depending upon the disease which is possibly there. For ramp, you would not want to use anti-VEGFs, which I understand you would possibly do a laser introp. And with these patients, you may repeat injections as well as TPAs if required as early as 1 week. This is what I think the crux of the entire program is. And one more thing, sir, which I would wanted to ask, you explained about the isotonic gas which you have used. So you normally tend to use 0.2% of C3F8 and then you make it to a 1 and then you give 0.5 of the entire 1 ml of the gas. So this is what you tend to do, and you don't like you tend to prefer the longer acting gases as compared to SF6.
Yeah.
And with respect to vitrectomy and FX, I think those are the cases when you are like eventually going and you do a complete vitrectomy, or you do a core and or maybe up to the equator and all those things.
I think Dr. Deepak spoke very well. You don't want to do vitreous-based shaving, but definitely you will induce PVD. And I think the bottom line is take it till it goes easily. You know.
Rightly said, sir.
Yeah. So don't force it beyond any point of strong adhesion. So and then what you do to that remaining frill doesn't matter. Rather, many times I feel like leaving a frill all around, it might help you get some better half-life for your anti-VEGF. If I don't know how much it will benefit, but leaving a frill or 360-degree is a I think good idea. It might retain some anti-VEGF if it works like this.
So can you just last question? Can you explain about the positioning of these patients when you give you want to do it for pneumatic displacement, or are there any contraindications if you have a patient with advanced cupping, or maybe the patient is not able to actually do a positioning? So how do you go about with them?
I think if there is advanced cupping, we can always give them mannitol also. If we are going for pneumatic displacement, you can give it in immediate post-op period. And why I want a bigger bubble on table itself is we ask them to maintain prone position in hospital itself for maybe couple of hours, so that trains them and ensures that at least some of displacement happens then and there only. Because compliance to prone positioning is also, you cannot rely upon. So that's the reason we want them to be prone in hospital for a couple of hours or more. And I think depending on gas, if SF6, even C3F8, seeing them next day and checking intraocular pressure is very important. And obviously, when you are using gas, sometimes it can misbehave. In general, I have seen C3F8 to be much more predictable than SF6. This I have seen. I don't know what's the experience of others.
Dr. Bhavik or Dr. Deepak, you want to add on this?
I think the sir rightly said all the important points. And we also are learning in experiences. And like I said, submacular hemorrhages, the first treatment which we do is a pneumatic displacement. If it fails, then only we do an invasive interventions. Regarding TPA, the experience, whatever literature I have heard, whatever I've read, this TPA concerns whether it can breach the retinal barrier, it can cross the retinal barrier to reach the subretinal space is a question mark. Second debatable topic is the dose. And the third, most important, because we are dealing with elderly patients, they already have so many systemic complications. They are prone to bleeding providences. So using such TPA, you may not get a physician's witness. That's why I tend to usually not use TPAs. And most important thing is you should know once the blood clears, the important message to tell the patient is the disease is not over. You might need additional treatments, because once you do a vitrectomy, the patient feels that the treatment is over. That's it. You usually will just get the glasses and the game is over. But these bleeds and hemorrhages, they keep on happening because the primary etiology is a CNVM, which is happening back of the end. Most common cause, which is noted in literature, is a wet AMD, followed by PCV, and the third is a ruptured RAM, followed by myopic CNVMs and idiopathic. These are the 5 most important things which you should keep in mind in the etiology when we are treating these patients. Thank you.
Thank you, Dr. Deepak. So thank you so much, Dr. Deependra sir, for your.
I have a question, Dr. Deependra.
Yeah, please.
Yes, sir. What is your preferred anti-VEGF now for PCV? Do you prefer something over the others?
I think either of two. If I think patient is not at risk of inflammation, I still go with brolucizumab. And if it is a bilateral disease, then I think nowadays what I am doing is I am doing a combination also. One eye I put on aflibercept and another eye on brolucizumab. Somehow I'm a little hesitant to put patient on both eyes on brolucizumab. And the faricimab is definitely there, but initial cost is like still higher side. If so, that's also a good option for these patients.
You're using a combination, then are you injecting Eylea more than you're injecting like in the other eye? The gap would be more, right?
Right. So I think I actually explained to them that I think because injection carries some risk of inflammation. So let's reduce your total number of injections, but not expose you also to too much of this strong injection.
Have you seen a case of IOI with Pagenax?
Yes. I think if you use anybody who have used more than 300 injections will encounter. We have had now 3. And luckily, all 3 are fine, and they were all. My usage of brolucizumab is primarily in AMD only, neovascular AMD. So we'll use it very less frequently in DME.
Thank you.
Thank you so much, sir. So thank you, everyone. Thank you, Dr. Neha, Dr. Deepak, Dr. Todi, Dr. Harshita, and Dr. Levin for your beautiful presentations. A lot of learnings from this. We would like to thank Manjula Madam for her support for the EV team, and thank you, my core team. We'll be back soon. Thank you, Deependra sir. Again, it was
Thank
beautiful.
you. It was a pleasure attending late night right now. So
Thank you so much, sir.
Feel like my fellowship days. We used to up late night. Thank you, and wishing all the young retina guys very best. All the best.
Thank you so much. Thank you, sir.
Thank you, everyone.